Today I'm going to talk about a case that's very interesting. Patient present with, I think it's a maybe 60-year-old lady, present with right side Homonymous hemianopsia with normal carotid ultrasound. This is my MRI report. I'll show you the MRI finding first. So basically, the patient has a large left side temporal lobe lesion with heterogeneous contrast enhancement, some part of even tracking along the left side cortical spinal tract. That's the size, and part of it enhanced, part of it doesn't enhance. This is the coronal images, and there's some 3 millimeter midline shift. So I suspect a primary brain tumor on this patient, like 61-year-old. The interesting part about this case is you can see the optic nerve, optic chiasm, and an optic tract. Usually the optic tract disappeared here into the parenchyma of the brain. You don't follow it. But because of the vasogenic edema on this patient, you can follow the left side of the optic tract clearly until it's joined the thalamus right here. Follow my arrow. This is the optic tract on the left side. That makes sense with the patient's symptom of patient's right side Homonymous hemianopsia. So I will explain that later. But anyway, this patient, I suspect a primary brain cancer such as GBM. Usually the enhancing portion are the higher grade portion of the brain. So if they want to biopsy this tumor, they better biopsy the area of contrast enhancement instead of the non-contrast enhancing portion. So I recommended biopsy here, and they did it, and then turned out to be a surprise diagnosis, which is called monofocal acute inflammatory demyelinating disease. You can look it up online, MAID, demyelination, and this is a good article. It has several cases about it. So anyway, it's interesting. Basically, it's a variation of multiple sclerosis. Maybe if you're treated with steroid, it could go away and then never come back. So a good diagnosis for this patient. What I'm trying to show you here is the Homonymous hemianopsia have injury to the optic tract. This area, this is thalamus. So we can follow this area pretty well on our MRI. Usually you do not have that luxury in other patients. Only because of the pathology you can see this tract well. That's it.